The session, let's see.
The session is Pediatric Symposium.
Well, let's start the Pediatric Symposium. I'm Fernando Cavalcanti from Brazil and Joe Romero from the United States. We are co-sharing this session.
For those of you who don't think I look like Joan Merrill, I don't. So I'm Joan Merrill's best friend stepping in, and I'm actually Jill Buyon. Okay.
I'm sorry.
No, that's okay, just in case people...
Well, we have three speakers today talking about lupus in children. And the first speaker is Dr. Clovis Silva. He is professor of pediatrics at the Department of Head of the Pediatric Rheumatology Unit at the University of São Paulo. You can start. You have 25 minutes, and after each presentation is open to questions.
Thanks.
Okay. Oh, good afternoon. I would like to thank the organizing committee for this invitation, and my presentation is gonadal function in preservation of reproductive fitness in childhood SLE patients. I will divide my presentation in two parts according to gender. In male gender, spermatogenesis starts at puberty with development of primordial germ cells from spermatogonia to spermatozoa with duration up to 3 months. A global evaluation of male fertility is required and includes urologic clinical examination, testicular ultrasound to assess testicular volumes and to exclude testicular disease, hormone profile with evaluation of FSH, LH, total testosterone, and inhibin B. In addition, sperm analysis and unsperm antibodies are the most important exam to evaluate male fertility. Genetic evaluation is required in patients with low sperm concentration. Karyotype or FISH analysis to exclude Klinefelter syndrome and polymerase chain reaction amplification of 3 regions of Y chromosome to exclude Y chromosome microdeletion. There are risk factors for male infertility in SLE patients. For general population, poor nutritional status, obesity, smoking, alcohol use, air pollution, radiation therapy, genital disease, for example, mumps orchids, varicocele, testicular cancer, sexual dysfunction, and genetic disease may induce male infertility. And there are specific risk factors for male infertility in lupus population: acute orchids or testicular vasculitis, autoimmune orchids with production of unsperm antibodies, and the most important risk factor, drug therapy. We recently revised the pathogenesis of autoimmune orchids. Inflammation, infection, or trauma on testicle may induce T-cell response with increase of cytokines, especially IL-1, IL-6, TNF-alpha, IL-12, 17, and 23, with alteration of blood test barrier permeability and production of unsperm antibodies. These antibodies may induce agglutination or immobilization of spermatozoa and provoke sperm-oocyte interaction. In addition, alteration of this barrier may provoke apoptosis of germ cells, especially spermatocytes and spermatids, and vessel alteration with sperm abnormalities and infertility. We also revised the effect of drugs on male infertility. Methotrexate may induce a reversible sperm abnormalities. However, spermatogenesis recovers 3 months after stopping this medication. The most important drug associated with male infertility is cyclophosphamide. Indeed, this drug may induce alteration of spermatogenesis and alteration of Sertoli and Leydig cells. Irreversible sperm alterations were evidenced with great dose of cyclophosphamide, generally over than 300 mg per kilo. No effect on male fertility was observed with the other drugs. We first evaluate a global gonad assessment in lupus patients without antiphospholipid syndrome, in 35 lupus patients and 35 healthy controls. And we demonstrated that lupus patients had severe sperm abnormalities compared to controls, with decrease of sperm volume, total sperm count, total motile sperm count, and sperm morphology. The most important risk factor associated with this decrease of sperm alterations was intravenous cyclophosphamide therapy, since sperm concentration, total sperm count, total motile sperm count, and sperm morphology by WHO guidelines were significantly reduced in patients treated with intravenous cyclophosphamide compared without this therapy. Importantly, the mean of last dose of cyclophosphamide was 5 years, indicating a persistent damage. Further analysis of other parameters of global evaluation, we demonstrated high levels of FSH in patients treated with cyclophosphamide and low testicular volumes in patients treated with dysalkylating agents with a similar frequency of sperm antibodies in both groups. Further analysis of cyclophosphamide damage, we performed a study regarding testicular Sertoli cell dysfunction in lupus patients, according to the levels of inhibin B. Inhibin B is a hormone produced almost exclusively by Sertoli cell function, and we demonstrated a reduced inhibin B in patients treated with cyclophosphamide. Even in 26 patients with normal inhibin B and normal FSH, a reduced inhibin B FSH ratio was associated with cyclophosphamide therapy and sperm abnormalities, indicating that this ratio may be a more sensitive marker of cyclophosphamide gonadotoxicity. And this ratio identified a subgroup of lupus patients with semen alterations and normal gonadal hormones. Chromosomal abnormalities have also been studied in male lupus patients. Klinefelter syndromes occurs in 1 to 3% of male lupus, and a study in the United States showed that this chromosome abnormalities is 14-fold more frequent in male lupus compared to healthy controls. We also evaluated 2 chromosome abnormalities in conjunction with other parameters of gonadal function, and we observed only 1 patient with Klinefelter syndrome, is a mosaic Klinefelter syndrome, and these patients presented only mild sperm alterations with abnormal sperm morphology and without a classical phenotype of Klinefelter syndrome. And none of them had Y chromosome microdeletion. Penile anthropometry and sexual function were also assessed in lupus patients. 25 lupus patients compared to 25 healthy controls. And the median of penis length was significantly reduced in lupus patients compared to controls, likewise the median of penis circumference. Despite of decrease of penis size, none of our patients had erectile dysfunction. The most important risk factor associated with reduction of penile size was lupus onset age, since the median of penile circumference was significantly reduced in prepubertal lupus onset compared to postpubertal lupus onset. None of our patients had complaints of small penis and sexual dysfunction. Gonadal function was evaluated in primary antiphospholipid syndrome, and the median of penile circumference was significantly reduced in PEPS patients that presented previous arterial thrombosis compared without these abnormalities. In addition, the median of penile circumference was significantly reduced in patients that present erectile dysfunction compared without this sexual dysfunction. None of our patients had penis edema or thrombosis. Therefore, a morphofunctional penile abnormality was observed in PEPS patients different from lupus patients, indicating a chronic subclinical endothelial dysfunction of corpus cavernosus. Testicular function was normal for this population. In SLE-related antiphospholipid syndrome, our group also demonstrated a reduction of penile size associated with previous arterial thrombosis and erectile dysfunction. Sperm abnormalities were also evidenced in SLE-related APS patients associated with intravenous cyclophosphamide therapy. There are general recommendations for testicular preservation in lupus patients needing cyclophosphamide. It's important to discuss family planning before cyclophosphamide use with adolescents and their families. Use lowest dose of cyclophosphamide in alternative therapy to this alkylating agent, azathioprine or mycophenolate mofetil after remission. There are options for fertility preservation in males needing cyclophosphamide. In postpubertal patients, no efficacy was reported with hormonal therapy with replacement testosterone therapy. There is only one effective and safe option for fertility in postpubertal male patients taking cyclophosphamide: sperm cryopreservation for future assisted reproduction technology, especially intracytoplasmic sperm injection. Therefore, it's important to collect one or more sperm sample before start cyclophosphamide in patients with Turner 2. In prepubertal patients, there is only one experimental technique in animal models: cryopreservation of spermatogonial stem cells for future autologous intratesticular transplantation. In female gender, ovarian function depends on primordial follicles. At birth, there are 1 to 3 million of follicles, whose number decreased to 500 at puberty. And each menstrual cycle, approximately 1,000 of follicles are recruited. However, generally one achieves maturity and ovulation. The others develop follicular atresia. A global evaluation of female fertility is also required and includes gynecological examination, pelvic ultrasound to assess ovarian volumes, and antral follicle count size between 2 and 10 millimeters. Ovarian reserve include evaluation of FSH, LH levels, and estradiol within the first 3 days of menstrual cycle. The most important parameter is anti-Müllerian hormone. This hormone is produced by granulosa cells of growing follicles and it's considered a reliable biomarker of ovarian reserve, unaltered by contraceptive use, and this hormone may be collected at any moment of menstrual cycle. As reported in males, there are risk factors for female infertility. Genital disease, for example, polycystic ovary syndrome, endometriosis, sexually transmitted disease, and sexual dysfunction may induce female infertility. In lupus patients, disease activity with menstrual irregularities and autoantibodies may induce decrease of ovarian reserve. And the most important risk factors is drug therapy with a consequence of premature ovarian failure. Regarding the effect of drugs on female fertility, non-steroidal anti-inflammatory drugs may provoke a reversible luteinized unwrapped follicle syndrome. However, ovulation and menstruation remain normal after stopping or decrease these medications. Glucocorticosteroids may induce a reversible hypothalamus pituitary gonadal X suppression, especially with great dose of prednisone over than 1 milligram per kilo. Ovulation and menstruation remain normal after decreases medication. And the most important drug is cyclophosphamide. This drug may provoke follicular apoptosis and follicular depletion. And premature ovarian failure was reported in up to 12% of pediatric lupus patients and from 10 to 60% in adult lupus patients. The most important risk factors associated with the precocious menopause are age greater than 25 years and high cumulative dose, generally greater than 5 grams. No effect on female fertility was observed with the other drugs. We studied the age at menarche in childhood SLE patients, and we demonstrated in Brazilian that the mean of age at menarche was significantly higher in childhood lupus patients compared to healthy controls. The delayed age at menarche seems to be not related to genetic background, since a similar maternal menarche age was observed in juvenile lupus patients and healthy controls. The most important risk factor associated with delayed menarche was cumulative dose of corticosteroid. A positive correlation was evidence between the glucocorticosteroid cumulative dose before menarche and age at first menstruation. Menstrual alterations were also studied in childhood SLE patients. A prospective study was performed by our group with 30 adolescent lupus and 30 healthy controls evaluating for at least 6 consecutive months. And menstrual abnormalities were significantly higher in pediatric lupus patients compared to controls, with a predominant longer length of menstrual cycles. We also performed in Brazil a retrospective multicenter registry, including almost 300 of adolescent lupus. And amenorrhea was observed in 12% of them, with mean duration of 7.2 months. And in multivariate analysis, the most important risk factor associated with amenorrhea were disease activity and cumulative damage. Importantly, in these studies, none of our patients had premature ovarian failure. Despite menstrual alteration, first sexual activity occurs at an early age in childhood SLE patients and health controls in our group, with mean of 15 years, as reported by other groups and as reported by healthy adolescents in America. With a consequent vaginitis by Candida in 14% of patients, and HPV infection in 2% of our childhood SLE population, with a risk of cervical cancer, as reported in one patient with 14 years old, and genital warts. We also evaluated pregnancy in a multicenter study in Brazil, and we observed that 8% of our patients had unplanned pregnancies. Early fetal loss occurred in 21% of them, and the most important risk factor associated with this pregnancy outcome was inadvertently exposed to cyclophosphamide, despite a strong recommendation for both contraceptive with condoms in all sexual activity and hormonal contraceptive for all patients. Ovarian reserve was studied in childhood SLE population. A retrospective study was performed in the United States and observed a reduction of ovarian reserve based on high FSH levels in childhood SLE patients associated with cyclophosphamide. 2 prospective studies were performed in Brazil, and we observed compared to healthy controls, and we observed reduction in ovarian reserve, including a new study with decrease of anti-Müllerian hormone levels. Importantly, none of them, in 3 studies, received gonadotropin release hormone agonists during cyclophosphamide therapy, indicating these patients present a subclinical ovarian dysfunction. As reported in males, it's important for female discuss family planning before cyclophosphamide use and uses lowest and alternative therapy to cyclophosphamide. Finally, there are options for fertility preservation in females needing cyclophosphamide. For post-pubertal patients, no efficacy was reported with hormonal therapy with estrogen-containing oral contraceptive or medroxyprogesterone acetate. There is one option, effective and safe option in adult lupus patients, a gonadotropin release hormone agonist. We are awaiting the results of triptyroline study led by Hermine Brunner in the United States and Brazil. So we don't have data of any gonadotropin release hormone agonist in pediatric lupus population. There are other options, and one option is embryo and oocyte cryopreservation. This is an effective option, especially for adults and especially for advanced age. However, this option needs ovarian stimulation before collection of mature oocyte and may induce risk for lupus patients with a probability of disactivity and thrombosis. For prepubertal patients, there are rare cases of pregnancies after ovarian tissue banking for future tissue transplantation. These options may be indicated in postpubertal lupus patients too. Our studies were supported by Brazilian fundings, FAPESP and CNPq, and Federico Foundation in Switzerland. I would like to thank our division and departments of our university hospital in São Paulo, Brazil. Thank you very much indeed for your attention.